I'm Dr. David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia. Well, quality is what the key is, and particularly for colonoscopy and risk reduction for cancer. As it relates to performance, we have a number of things that we recognize in our own practices that we can do better, and certainly you've seen this with your colleagues. We've seen it with patients that have had a colonoscopy, have an interval cancer. There are several studies that have just come out, and I really want to put profile around some of these to give you, I think, actionable items that you can prescribe now, and certainly look for guideline evolution to really further support. But the evidence is extraordinarily strong that these things should be actionable now. Let's talk about first adenoma detection rate. Certainly, we all do things that we can try and attribute to increase the adenoma detection rate. Recognize the ADR, if you will, is 25%, which is inordinately low. The new norm for in the GI quick data is closer to 35 to 36%, and high-level detectors are actually in the 50+% range. So there's no question that we can do more. There are a number of ways you can do that. One is the exposure techniques that you can do with your colonoscopy, use of a hood or cap or a device that faces the mucosal folds coming back. This may actually increase your or decrease your withdrawal time because you don't spend so much time trying to face these folds. And certainly don't forget the chromoendoscopy or the electronic chromoendoscopy with NBI and such. There are a number of things with artificial intelligence that are out there. These seem to increase the ADR approximately 10%, even among experts, and that's really important to recognize. An emerging data also is it relates to adenoma detection rate in FIT-positive patients, and this is really important for you to recognize. The FIT-positive changes the numbers by 15 to 20%. So increase the FIT detection ADR by 15 to 20%. You're probably in the range of 50%, which is really the norm for FIT-positive type screening patients that now come for colonoscopy because of FIT positivity. Growing evidence that supports the adenoma per colonoscopy, or the APC, and this has been evaluated most recently from the New Hampshire colonoscopy registry, and this is certainly Joe Anderson has been a lead on this for so long, but nice paper looking at this and showed that the APC value should be around greater than 0.6. So you would record every adenoma and that attributed to that index colonoscopy, and 0.6 is the number. Less than 0.6 seems to be associated with interval increased risk of colon residual polyp, cess-ulcerated lesion, and increased hazard ratio for colorectal cancer as an interval. If their patients are in their study had even the adenoma detection rate of 25% or greater, they still found 21% had APCs that were less than 0.6. So again, remedial type patients, these doctors need to be reevaluated and retrained, and certainly educated in ways that they can attribute this. APCs in high-level detectors is greater than 1. So APC may be something you really could look at internally, but does require that you place each polyp into an individual jar, which increases incremental cost. But nonetheless, there is a clear evidence that this changes outcomes. As it relates to other things related to cess-ulcerated lesions, these are something that, again, are increased recognition. Unfortunately, some of the high-level ADR detectors aren't so high-level cess-ulcerated lesion detectors, so it's a lot not quite as concordant as we had previously thought, but nonetheless, cess-ulcerated lesions, again, using adjunctive things that you can do. NBI is a great one, chromoendoscopy is a great one, but these are things that we recognize. Again, discriminant that the number should be 5 to 6% relative for if we're going to set a quality ratio and an index, but it's somewhat discriminant based and dependent on your pathologist because they have to read these correctly. And so lesions that were greater than 6 millimeters or greater above the sigmoid colon in particular, anything in the right colon, it should be evaluated really closely as a cess-ulcerated lesion. And I've had indications where I just flat out, the pathologist says it's hyperplastic, and I just said, I'm going to follow this as an SSL because it's too apparent to me. And the appearance, the endoscopic appearance and the NBI appearance were just, to me, were characteristic of cess-ulcerated lesion. So again, cess-ulcerated lesion, if you're going to use a number, 5 to 6%. Bowel prep indicators, again, still 85% from the U.S. Multi-Society Task Force, the European Society, 90%. A tip here is I use my patients are aware that want to see the color of clear yellow like urine, because a lot of patients still, they have some diarrhea and they think that they don't have to finish prep. I've already had some diarrhea. So setting that expectation for the patient is really important. The nurses also should be aware of this because a a murky brown effluent on presentation to the endosuite in preparation for the colonoscopy, there's a 50+% chance that they're going to have an inadequate preparation. So you would want to preempt that colonoscopy, maybe send them out for a re-prep that day or bring them back on a rescheduled. Resection is very important. We do know that there are variations on resection, so high-level detectors aren't always high-level resectors, which is really an important point to recognize. There are a couple of validated instruments that you can gauge the adequacy of resection. Those aren't really ready for prime time in every practice. They may be in a fellowship program. But the idea here is that you want to get a 2 millimeter or greater for cold snare polypectomy. We're talking about lesions 1 to 10 millimeters. And these are things that really have been now challenged that we don't do that well. The White River Junction, Joe Anderson and his group, and the Dartmouth VA have just looked at this. Using a 2 millimeter resection, there were only about 28% that actually met that criteria. 1 millimeter was 84%. Again, we just need to set our margins clear when you set your snare. Make sure you're close enough to it. You can push down on the snare, but get a good margin of tissue. Recognize pathologists, because it contracts when it gets into the formalin. It does not, it's not quite so simple as it relates to the margin definition of width at the time of the surgical resection audit evaluation by pathologists. Two other things about resection. One is the referral for surgery. It really should not be done for anything that's benign lesion that are ascribed by your endoscopic advanced imaging techniques and classifications, that they are thought not to have intramucosal carcinoma, but they are just benign lesions. These should be referred to an endoscopic evaluation for an expert, that if you can't do it, then somebody else should, and you shouldn't attempt it unless you think you can get it totally, because resection of partially resected lesions much more complicated. The European Society says any benign lesion of any size, and I think that's pretty much the growing standard here. You should at least consider that and offer that to the patient. Again, may obviously be referral out of your institution, but it really is an emerging standard of care. Another one that is a quality indicator that I think is really important is the minimization of cold forceps for removal of polyps. The U.S. Multi-Site Task Force said anything over 2 millimeters should not be used for a cold biopsy, and this is something the European Society said anything over 3 millimeters, but it's still done very commonly in clinical practice, and nibbling the polyp is not an option. Cold snare is actually quicker, more effective, and certainly has better outcomes, and is something that you get billed for when you start to look at the coding of these things. So there are a lot of things that we can do now. These quality indicators continue to emerge as far as evidence-based, strongly supporting all of these, and I think they're actionable at this point, and not necessary to wait for the guidelines to incorporate all these. I think we have excellent evidence now, and I put these to a challenge to you. I know we can all do better. Dr. David Johnson, thanks again for listening.